Today our topic is rheumatic heart disease. So rheumatic heart disease is actually the cardiac manifestation of rheumatic fever. So what is rheumatic fever? 4 points are very important from rheumatic fever. One is that it's an acute condition. Second, it is immunologically mediated. Third, it's multisystemic. And fourth, it is an inflammatory condition. So now let's move toward the pathogenesis. So it's actually a hypersensitivity reaction. Antibodies that are formed against group A beta hemolytic streptococci. They cross react with host myocardium antigens. As a result, there will be activation of complement and Fc receptor bearing cells, and both of these causes injury. There is also activation of CD4 T cells that recognize these strep peptides, and cross reactivity occurs, and cytokine mediated inflammatory processes occur, and they causes injury. Whole heart can be involved, but mostly there is valvular damage. There is valvular inflammation and scarring, and as a result, we have deformed fibrotic mitral stenosis. It's the only cause of acquired stenosis. It occurs 2 to 3 weeks after strep infection. Now let's move toward the morphology. So acute rheumatic fever, it mostly presents with inflammatory lesions within a variety of tissues. Escuf bodies are actually the inflammatory lesions that are present within the heart, in the myocardium mostly, but sometimes in the pericardium as well. They consist of lymphocytes, scattered plasma cells, plump activated macrophages that are known as NH-core cells, as well as caterpillar cells. So in the center we have zones of fibrinoid necrotic area, that is the core, and around inflammatory cells are present. Okay, so these caterpillar cells, they have abundant cytoplasm, and they have condensed wavy slender ribbon like chromatin. Okay, so it is actually present as pericarditis. Pericardium, there is fibrinous exudate that resolves mostly. Myocarditis, scattered escoph bodies within interstitial connective tissue, and Vizuki. They are actually the fibrinoid necrotic area along with fibrin deposition along lines of closure. So we have mouthfish, a fish mouth, and buttonhole stenosis, and in these, this is actually a manifestation from chronic rheumatic heart disease. So here we have, in case of chronic rheumatic heart disease, the acute inflammation is actually organized like the escoph bodies. They are replaced by they are converted into fibrous scar. Here the inflammatory cells are present around the necrotic area, but in case of chronic, the inflammatory cells, they are going to be replaced by fibrous tissue. The cusps and the leaflets, they become thickened as well as retracted. As a result of the retraction, regurgitation occurs. The commissure, their shortening occurs, and as well as fusion. As a result of the fusion of commissures, there is stenosis, and chorda tendini, they also thicken and fusion occurs. So fibrous bridging plus calcification and neovascularization can occur, and diffuse fibrosis is present. So we have valvular stenosis and regurgitation. Mitral valve is mostly involved. In 70% of cases it is involved. Mitral plus aortic 25% cases, tricuspid is lessly involved, and pulmonary mostly spares. In 70% of the cases, mitral valve is involved, and it is present between the left atrium and left ventricle. So when its regurgitation occurs, the left atrium, it actually dilates, and because of the dilation of the left atrium, there will be stasis of blood in the left atrium, and as a result, thrombosis occurs, and a part of the thrombus can detach and serve as embolism. So there is increased pressure in the left atrium. So if that pressure, as a result of that backup pressure, there will be pulmonary congestion and pulmonary vascular changes as well. So pulmonary hypertension can occur, and then the right ventricle has to pump blood against high pressure, high pulmonary hypertension. So as a result, we will have right ventricular hypertrophy. Left ventricle mostly spares in case of rheumatic heart disease. So clinical features, It mostly presents 2 to 3 weeks after streptococcal infection. And fever and migratory polyarthritis. This migratory polyarthritis is very important. So culture can be negative because of this gap, but antibody titer can be positive, and ASO and again Jones criteria, it's very important for the diagnosis. So if you like this video, click on the like button and also subscribe to the channel. Thanks for watching this video.